think they set up too many chairs.
It's all good. It's good to be optimistic. And hey, sometimes it's more, sometimes it's less. All right, tonight we're going to be discussing the Lazarus syndrome. And this builds on what we started the year. Remember when we brought in the mannequin to be able to give us feedback on how we were doing CPR, and we said, throughout the year we were going to be doing different things to build on our resuscitation, and we have been. And tonight is a relative to some of the other drills, relatively brief but important discussion about the end of life, or is it? So when we bring up Lazarus syndrome, a lot of people don't realize even what it is. I didn't know when someone had first brought it up to me. And it's also known as something called autoresuscitation. So it's the spontaneous return of cardiac activity after someone is pronounced dead. Just like the story of Lazarus from the Bible. It's like somebody's coming back from the dead all by themselves. Not being resuscitated by EMS. They've been pronounced dead, our resuscitation has stopped, and then it turned out they're alive. Or they regain pulses and cardiac activity. And there have been almost 80 documented cases since it was first reported in 1982. Now, there's a lot of etiologies or causes for them. And you see the whole list here. Anywhere from they had a heart attack, but they weren't quite dead yet, to obstructive airway disease, all different things that cause someone to go into cardiac arrest across the board. And all of these types of cases have had people who were pronounced dead at some point in full cardiac arrest, pronounced dead, resuscitation had stopped, and then they were found to have pulses and circulation. What kind of cardiac rhythms? Most of these patients were in asystole or flat line, but there were also patients who were in pulseless electrical activity, meaning that there was still some kind of electrical activity in the heart, but it wasn't producing a pulse. Sometimes that's because the electricity is going through and the heart itself, the muscle in the heart, is not moving, even though the electricity is going through to stimulate it. Other times, the electricity is going through and the heart is moving, but maybe it's because it's squished down by blood in the sac surrounding the heart, or a tension pneumothorax, too much air in the chest that's squeezing down on it, or maybe it's just flat out that because of dehydration or bleeding, the heart is pumping, but there's nothing to pump. So all different reasons. Even ventricular fibrillation, of course, a shockable rhythm. So all of these have been documented also to have cases of Lazarus syndrome. So disposition, in other words, okay, so these people are found to have a pulse, right? Cardiac electricity, yes. Cardiac activity and pulses. But about half of them had neurological activity after return of spontaneous circulation. That's what ROSC or ROSC is. Return of spontaneous circulation. So that's the phrase that means we got pulses back. So they got pulses back, and about half of them had some kind of neurological recovery. And about 25% in total went home neurologically intact. And they have a specific scoring system for that, but I didn't bother. I didn't want us to get too much more bogged down in numbers, but essentially they were able to go home and take care of themselves. When they say home neurologically intact, they mean they're able to take care of themselves, that they may have some memory loss or some other impact, but they can take care of themselves. About 10% of them, unknown, undocumented. Unsurprisingly, I think when you think about it, that sometimes when someone declares a patient dead and then later on they say unzip the body bag and find that the patient is breathing, they don't always document all of that perfectly the way that they should. Go figure. So it's not surprising, right? We don't always have all the facts and figures. So possible pathophysiology. In other words, how does this happen? Like, what are the mechanics behind this? Well, there are some primary theories. One of the biggest one is air traffic. And it's what it says right there, a buildup of pressure in the chest in CPR, okay? So they're pumping and blowing, doing resuscitation, but very often, especially over ventilation. So too much ventilation builds up in the chest, all right? And we know that. In fact, we even talked about that and we showed that when we were using the mannequin. It's very easy to overventilate patients, especially smaller, more frail patients, little kids, yeah, too, but small, frail patients. And then when we, unsurprisingly, when you think about it, when we stop pumping all of that pressure into the chest, after resuscitation ends, it relaxes, allows the heart now to be able to resume beating. Maybe it was weak, and all of that ventilation, because remember, it's doing a couple of different things. All of that ventilation, if you remember, number one, the heart has to pump blood through the lungs, right? Right? And then back out to the rest of the body. So if you're overinflating your lungs, right, you're creating a lot of pressure on those capillaries that are inside the lungs. If we're ventilating the heck out of this patient, positive pressure, right? All of those capillaries get squeezed and squished down. You get, because remember the alveoli. You've got the air side, right? This is the part that fills with air, and all surrounding it is the blood vessels, the capillaries. So normally you want this to fill up with some air, and the capillaries, the blood pumps through them, exchanges gas, and all is well. But when we're trying to help this person, we're trying to save this person, someone's going in, and then big guy like Rich is ventilating down. And I'm not implying anything, but it's easy, especially when you're, proportionally much bigger than the patient and you're squeezing down. Now the air is really expanding and it's crushing down on those capillaries. Well, those are little capillaries on one branch of the lungs, but altogether, that's all of the blood in the body. All of the blood in the body gets pumped through the lungs. So the heartbeat trying to push blood through those capillaries as all of those capillaries are being squished down just by your simple overventilating. If the heart's weak, it's not going to be able to do that. No pulse. But on top of that, you also get that overventilation, that buildup of pressure. As the lungs expand, they're not only crushing against all of the little capillaries, what's sitting right in between both lungs?
Heart.
The heart. So literally as the lungs overexpand, hyperinflate, they're squishing down on the heart itself. So if this heart wasn't doing too well in the first place, then it's already not going to be able to pump through the capillaries, and the lungs are squeezing down on it. And I got one more thing for you. We're ventilating. We're building up, we're hyperinflating those lungs, right? We'll take one more step out. As we hyperinflate those lungs, the pressure in the whole chest cavity is pretty high, right? It's increased. Well, remember, blood has to flow back to the heart to get pumped through to the rest of the body. Well, if we're hyperinflating the lungs, we're also creating so much more pressure in the chest, and it's harder for blood to passively return to the heart. So we got three different ways that overinflation of the lungs. And don't get me wrong, we know now more than ever, it is important to ventilate patients and open up those parts of the lungs. That is important, and we want to oxygenate the blood, absolutely. But you have to be so careful. There's three different mechanisms by which extra air in those lungs is going to shut down the circulation. So one of the big things for Lazarus syndrome that makes us think a little bit about all resuscitation and how to do it well is that hyperinflation of the lungs through three different methods causes a shutdown of circulation. And when they just stop ventilating them, the heart's able to pump blood through the body and they get pulses back again. So that's the hyperinflation and auto PEEP. So in other words, when we're just maintaining that the PEEP is the positive and expiratory pressure, which means that even after you let go, the patient retains air pressure. So it's not sort of, squeeze the bag, inflate the lung, let go of the bag, the lungs completely deflate. It's sort of if that makes sense.
Not those.
Right. So that's probably the big one. A second one related to this, if the circulation is slowed down, then resuscitation drugs like adrenaline, that get into the body. You know, we put epi in to help resuscitate the patient. Well, if the circulation is slowed down, then those medications that are supposed to help resuscitate the patient don't really go anywhere until we restore a little bit of circulation, and then those medications start to do their thing. So again, once positive pressure ventilation stops, interthoracic pressure decreases, so the pressure in the chest decreases, allowing the medications, you know, which are in the arm or leg or wherever the IV or access is, finally get to the heart. And if the patient is severely acidotic, so remember, you know how people who run, you get running cramps, right? And you get a stitch. That's the buildup of acid as your body doesn't have enough oxygen to do all of its normal metabolism. Well, the more acid that you build up, it kind of screws up all of metabolism. So it's kind of this balance. It's like I'm not getting enough oxygen for my body to do all of its normal workings and make energy. So the body has this backup mechanism that they're like, look, I can put us on the backup generator, but it's gonna stink. And you're like, well, we need the backup generator, so yeah, fire that thing up. Okay, but it's gonna stink. And the stink is the acids that it builds up. Like, look, you don't have enough oxygen, I can make energy without oxygen, but it's gonna make all of these acids all over the place. Okay, do what you gotta do, okay. But these acids are gonna further screw up metabolism. So it's like a last resort backup that the body has. Well, if the body is acidotic, has all of these acids, not only is metabolism screwed up, but the body's reactions to medications will also be way off, right? So again, as the body sort of, as we stop resuscitation and the body starts to go back to a balance, its normal balance, then all of a sudden the drugs that are still circulating can start to take effect and the person gets resuscitated. Spontaneous plaque dislodgement. So someone has a heart attack, they call it plaque. Just think of it like a plug, right? So a plug in the coronary artery gets plugged up there, thunk, and there's no circulation to that part of the heart, and the heart can't beat properly. Well, sometimes a clog can just spontaneously become unclogged and return circulation to the heart. Sometimes they're untreated reversible causes. So the acidosis, hyperkalemia, or other disturbances to the body's normal function, to the body's normal metabolism happen. And when we stop resuscitation, things start to balance out sometimes. Normally, of course, the goal of resuscitation is to help balance things out for the patient quickly enough to keep them alive. But sometimes we swing the pendulum, or not necessarily we, but sometimes the pendulum gets swung a little bit too far, like we were talking about, somebody trying to help and overventilating the patient. And then when we stop, things balance out enough that it kicks in. This is certainly not true for every single patient, but here are some of the reasons that they suppose. And myocardial stunning. Literally a combination of stunning, because when I've asked, okay, well, what exactly do you mean by myocardial stunning? Well, a couple of different things. One is the stunning that occurs when the heart loses circulation, like has a heart attack, and just sort of stops working correctly. But also the acidosis that we were talking about before, and even the function of just aggressive CPR, aggressive compressions, can cause a degree of myocardial stunning where the heart just goes and just can't beat. And when we stop, it recovers and resumes beating.
Well, Frederick says trauma itself.
Yeah,
It's the
absolutely.
trauma on top of-
That's an excellent example, excellent example. And it's there's actually a name for it when somebody gets like hit in the chest with a softball and it goes whack hard enough, not just to explode the heart, but to stun the heart into not beating. It's called commotio cordis, and whack, and the heart just goes. It just stops. Right, and hopefully starts up again, not always. Right, exactly. And there you go, along those lines, that transient asystole. In other words, whatever combination of chemicals or circumstances cause the heart to just stop beating for a while. Hypothermia is another reaction. We've talked about, not that long ago, we talked about different environmental conditions. And even though we talked about it during the summertime when it was hot, we did talk about hypothermia and heart rate and contractility, so the force that the heart beats would slow significantly. And let's face it, you knew this one was coming up at some point. Sometimes the patient wasn't completely dead and there just wasn't an adequate assessment. Yeah, they look dead. Okay, my job here is done. I'm going back in service. So where does it happen? Like, how much is this something that we would need to be concerned with? Why we're talking about it? Well, we're talking about it for two reasons. One reason is when we talk about all of this stuff, it lets us know, hey, when we're resuscitating, let's make sure that we're bringing our A game for resuscitation and not over-resuscitating. Good cardiac compressions are important, but not just wailing on the chest as hard as we can. Ventilations are important, but it is really hard to get good balanced ventilations and not over-ventilate or under-ventilate, and we're not really doing it. So that's one, but another one is, how relevant, how is this something that could happen in New Fairfield? Okay, well, here's one of the earlier ones, this was one of the ones that happened just last year. Yeah. Skilled nursing facility, she was presumed dead, found gasping for air in a body bag at this Iowa funeral home. She was at a hospice facility and they were like, yep, she's dead. They literally put her in a body bag and shipped her off to the funeral home, and they went, oh my goodness, she's moving, she's breathing. Okay, but that's skilled nursing facilities, right? And again, it's not just out in Iowa, it happens in New York as well. But not EMS, right? Well, that's a dead woman found alive, file lawsuit, Southfield paramedics and EMTs. They declared her dead, but she wasn't. But not firefighters, right? Well, no, absolutely positively in Detroit. And they called an ER doctor for a death pronouncement, but they did not actually do any assessment. They were trying to sort of pass it off to the doc so that it was the doc's problem, and it became a whole huge thing. I put up a QR code because I know I'm going through these pretty quickly, but if you read the incidents on any of these, they're pretty frightening. Ohio paramedics fired after incorrectly declaring a woman dead, and the chief and assistant chief were put on leave for supporting the whole culture that, in this case, not only did they not properly assess, but then they tried to lie about it after the fact. It was really, really terrible.
What a shame for the family.
Yeah, and that was just in April. And this is the thing, is you would think like, oh, well, this is so, I'm going to be pulling cases from like, this happened in 72, this happened in 83, this happened in 94. These are all just cases in the past couple of years. Florida medics disciplined, it gets crazy. It gets crazy. So here are the 5 factors of death, okay? When we say 5 factors of death, these are ways, before we were talking about resuscitation, and now we're talking about when not to resuscitate a patient. So this is straight out of the state of Connecticut protocols, right? So
Okay.
I've confused myself with the pick one. Which ones are these? Hold on a minute.
Try fish.
Oh, hold on, wait. I'm not gonna lie to you. I have them switched because I wound up switching.
Hate when that happens.
Yep, I switched them. I apologize.
No, it's okay.
That's why I was all confused.
Yes.
We just wanted to see if he knows.
Thanks, I appreciate it.
You passed tonight.
Teacher gets an A plus.
All right. And,
There we go.
all right.
Take two.
So 5 factors of death, okay. If you find all of these, then this is a patient we would not resuscitate. So unresponsive. So we find and document these, I should say. We find and document these. And if you're in a situation where you're calling medical control to say, hey, we've got dispatched to a cardiac arrest and we believe that this patient should not be resuscitated, that they're gone. This is not going to be any chance of a successful resuscitation. They are unresponsive. They are apneic. How long do we check?
30 seconds.
30 seconds.
And everything is a minimum of 30 seconds. No pulses, and they want you to check, if possible, all 3.
Okay.
Now I realize that's not always practical, but they want you to at least attempt checking all 3. No heart sounds, so they want you to feel for a pulse and they want you to listen for heart sounds.
It's on that.
And one more, unresponsive pupils. Okay, so they want to confirm there is no neurological activity. That's what that is for, right? Because the pupils are directly connected by the optic nerve, right, directly to the brain. So it's not going to rely on any kind of cervical, it's going to bypass any cervical neck injury or anything like that. If the pupils respond, there's still something in the brain. It doesn't mean that they're going to come back and be able to take care of themselves or that the resuscitation is going to be
But there's
successful.
some electrical activity.
But there's some electrical activity, right? So, the 5 factors of death, test question. Unresponsive, apnea, no pulses, no heart sounds, unresponsive pupils, and you have to find all of them. Now, this one's a little bit easier. The 5-ish signs of death, any one of these, and we don't need to resuscitate. So,
Decapitation.
damage incompatible with life, exactly. So decapitation, transection of the thorax, right? Like they're cut in half, anything like, basically crushed in, caved in head, even if it is attached. And this is where it comes, it's worded very strangely in the state protocols. So that's why the state's like, oh, they're just 3 things. But then all of these things have to be together and they count it as one thing. It's weird. So lividity and rigor mortis. So what's lividity?
Lividity is the dropping, the blood pools.
Pooling of the blood, right. So if someone's found laying on their back, it would be, on the bottom half and the back, the buttocks, the thighs, right? But if they're found in a chair, it's probably going to be, from their knees down. So anywhere, right, exactly. And rigor mortis is? Right. Absolutely, absolutely. Right. When you push down on their head to open their airway and their feet come up. Exactly. Thank you. Exactly. So, if someone's a paramedic and they see lividity and rigor, all right, because lividity could just be bruising by itself and rigor could just be arthritis by itself. But in the context of we went for a cardiac arrest and the person is, has pooling blood and rigor, then a medic has to check for electrical activity in at least 2 leads, and EMT must consult direct medical control. So,
In Connecticut, can an EMT pronounce?
100%. Well,
Well,
not pronounce,
okay.
but do you have to have a medic there? No. Can an EMT call direct online medical control and go, and yes, I'm sorry, we're turning this over to the police, we'll need to call the funeral home? Yes.
Okay,
Does that help?
yes.
Okay.
Because someone asked me before, And
Yes.
I wasn't sure what the answer was.
And that's relatively recent that they've clarified that. And major trauma with no organized electrical activity in 2 leads. So in this case, it's sort of like, okay, well, you can't exactly say that they were decapitated or transected or incinerated and their whole body is burned, but like, they are an absolute unmitigated wreck. You know, I'm sorry, they got run, it was 37 and 39, and somebody just got crushed between 2 cars, a pedestrian coming out of Mobile, and they got crushed between 2 cars, or something terrible, God forbid, right? But if there's major trauma with no organized electrical activity in 2 leads, then any one of those, and we wouldn't necessarily have to resuscitate. All right?
That was the five-ish.
Yes.
There's only 3. 2 and 1.
Plus 2. I know. And one of them was lividity and rigor, so at that point I was like, oh, come on, guys. So, okay. So 5 long-term tips. Have a great resuscitation program. Ways to avoid the Lazarus syndrome. Not only the, we thought he was dead, but also all that stuff that we talked about in the beginning are to make it more likely that the person is just going to be alive in the first place, that we're going to be able to successfully resuscitate them. Have that good resuscitation program. Follow the resuscitation program. Again, here I'm talking about things like, and I know not only was I taught this way, I have taught other people this way, that like, we need to get in there, I want you to ventilate, and I know they told you to breathe 1, 2, 3, 4, and 5, and breathe, but I want you to get in there and just and now we know through 3 different mechanisms that actually makes things worse. Like good, you know, A for effort, okay, but we gotta back it down because you're actually making things worse. Have good resuscitation policies, and this is all stuff that we've been building on this year, and follow those policies and practices. You know, actually do the things that we say that we're going to do, and good documentation. That's why I brought up, and we'll see it one more time before we wrap everything up, that's why I brought up the state protocols. They're very, very clear. And one of the things they did in a recent revision of the state protocols is they made it even more clear. Their message was loud and clear from the state medical director and really all, Dr. Rich Kamen, and really all of the medical directors around the state. They were like, look, we're tired of people going, oh, well, when I go to resuscitation and when, you know, how I determine death is, I check this, this, and this. Oh, I check this, this, and this. Well, I check this, this, and they're like, no. State protocols, everybody checks these things. Period, end of story. The protocols are accessible to everybody. Everyone should know them if you're practicing medicine, because this is what we're supposed to follow. There you go. So, on scene, don't hyperventilate the patient. See if you can identify and treat reversible causes. Now, most of the time, this is something like that the paramedics are going to be doing, but we do it in conjunction with the EMTs. The paramedics may be giving an advanced treatment or medication to help reverse something or balance acidosis or whatever it may be. They give more adrenaline, who knows what. They may give a variety of things, but we have to find out what was going on with the patient. What might have put them into cardiac arrest? Because that's going to direct us on what underlying things we can fix so that good CPR and defibrillation will help bring them back. You know what see what I mean? I mean, anytime I think about resuscitation, and this is a thing that I get, like I say, I do get a chance to talk to the people who really, really study this stuff. And we're really lucky because now we're finally in a time where the people who are like the real research geniuses are also the people who are working in the emergency departments and in the field and in the ambulances. You know, they really understand it. There's not the scientists and then the people who are doing it. Now, the scientists are the people who are doing it. And what they all wind up saying is what resuscitates people is good CPR, good chest compressions, balanced ventilations, and good defibrillation. And all of those reversible causes, the acidosis, the anaphylaxis that the person, the asthma attack and constricted airways that caused them to go into cardiac arrest, whatever it might be, those are just the barriers to CPR and defibrillation bringing this person back. So like the paramedic's job is to try and identify and remove those barriers, but it's still CPR and defibrillation that's bringing people back. There's no magic one medication. Like when I first became a paramedic, that was like the big thing, man. I know we're still looking for it, but we're figuring it out, and that's why I get to swoop in and really save people. And I just need a cop or a firefighter or an EMT somewhere to do their little pushies for a while until I, the paramedic, with my paramagic, was gonna save this person's life with my magic squirty juice, right? And it turned out, over the years, the more we learned and the more I got comfortable with the idea that, like, no, it's working together for solid resuscitation. It's CPR and defibrillation. That's what saves people. And it's the paramedic. We're just removing the barriers to that saving people. Ensure the patient is warm and dead. So if they're hypothermic, and I know we're starting to transition to the, freezing cold and wood stove, and finally the bears go away and stop knocking over our garbage part of the year, that these patients get colder and colder, and we want to make sure that they're warm. Once CPR ceases, if we're going to terminate resuscitation in the field, someone's going to stop. Somebody needs to be around this patient for another 10 minutes.
Just in case.
Yeah, because virtually all of them were identified as we could have been able to tell this within 10 minutes. So when I say, resuscitation ceases and then the extra pressure releases and all that stuff that we talked about in the beginning, it's really going to be evident within about 10 minutes. This is not something that takes, 1 to 8 hours to achieve. The balance happens pretty quickly.
Well, you've seen the case studies where it says that the paramedic or the other EMTs say, oh no, it's just agonal, or it's just the body doing a reaction.
Right.
But it was actually the person trying to breathe.
And if it's still going on with 10 minutes, I'm sorry, but we got to keep resuscitating. Yeah, exactly. And I know this is it should be a no-brainer, but so here's the thing. We've been talking about this a bunch more because with the advent of more and more recording devices out there, we've also found that we wind up seeing on YouTube and on fireengineering.com or ems1.com or any of those, you just YouTube, right? Recordings of EMS people doing some pretty heinous stuff sometimes, right? And the thing is, it does happen out there, and as much as I wish that we never had to see that, what bothers me more than one person going off, maybe they're a jerk, maybe they're in their own crisis, right? Without even judging that, I do look at the other people standing around them and go, how is no one even saying anything about this? You know what I mean? So, and that's really what it's about is, man, I don't know, somebody, maybe they're having a brain fart or they're just having an awful day. They've got so much stuff going on at home. I don't want to make excuses for people, but okay, at some point we all screw something up, but that's why they have us all work in a team, right? Somebody's got to say something. Even if somebody's, one person's an EMT and the other person's a paramedic, it doesn't matter. There's no authority gradient. We're all we may play different positions on the team, but we're all on the same team. And somebody's got to say something. Fully assess your patient and fully document your assessment and treatment. And all of those points that we were talking about before, I make sure, I know some of the things that I say is oh yeah, I realize that the underlying causes and this, that, and the other, those are more paramedic things. But I want to make sure that we're all aware of what the expectations are for EMTs and paramedics, because the EMTs are there to hold paramedics accountable too. Again, we're all on the same team. There's nobody who's one above the other. We're just playing different positions on the team. So, if we're talking about it This is an unfortunate thing, but it is part of the Lazarus syndrome, and I think it needs to be part of the conversation. 5 tips for sudden unexplained infant death syndrome. And believe it or not, this is also straight in the Connecticut state protocols.
Okay.
So, for infants, so less than 12 months, these are the things that we're looking to document specifically with them. Apnea, asystole, flatline, lividity and rigor, like we talked about, and they want you to record the carbon monoxide level in the room.
How can we do this? Well, we have to.
Do you not have a CO meter
We had.
available?
It doesn't seem to be on there anymore.
Okay, but still, is it on the engines, the rescue, or?
Yeah, it's on the list.
Okay, all right, then it's something that you may want to have called for, yeah.
It doesn't matter what time of year?
No, it doesn't matter what time, they're not explicit in it. Yeah.
They don't do that for other people?
No, and here's what I believe, and this is totally just Ron Duckworth's best guess. We know that infants are more susceptible to carbon monoxide poisoning. So, I think it's reasonable for us to guess that when the medical directors were getting around and they're like, okay, so what have we found as a cause of this? Well, there were low levels of carbon monoxide in the house, low enough that it wasn't gonna kill the adults, but it did kill the 3-month-old.
That's the canary in the coal mine.
Kind of, yeah, right? So I think they thought, well, then we need to, we need to routinely, that's routinely available to EMS. May not show up with the ambulance, but first responders can call a fire department and somebody can monitor the CO. And apparently it's happened frequently enough that in the state of Connecticut, they want that done for the kids.
Our pulse ox, it's not working, so they were getting another one, but we haven't gotten it yet. That's because we did the big, more expensive pulse ox that had that, but right now it just has little finger things.
Right. The, I know the one that you mean, the Massimo, yeah. All right, and so I wanted to show you, because I've mentioned several times, it's in the state protocols, that this is one of the ones that they revised, 6.17, resuscitation, initiation, and termination. So, dead on scene, factors of death. So signs of death, as we said, factors of death. So signs of death: unresponsive apnea, no palpable pulses, carotid, radial, ephemeral, unresponsive pupils, and the absence of heart sounds. I flipped them around a little bit in order just to make it a little bit more the way we would normally do it. Factors of death, at least one. Damage, and as you said, decapitation, decomposition, incineration, deforming brain injury, meaning like a majority of the head gone and brain matter out. Lividity and rigor, both at the same time. EKG from paramedics, EMTs consulting direct medical order, direct online medical control for orders to presume death. And I love how they major blunt or penetrating trauma. Well, those are the only 2 types of trauma. So, so major trauma without electrical activity, and there again the sudden unexplained infant death syndrome. So I don't know why exactly they added the unexplained. I think that was, just to say we don't know why. They're trying to clarify.
Is the CO just to try to explain it?
Yes, to try and explain the unexplained. And that's it. As I said, this one's a little bit of shorter.
Do they update that once a year?
The
I have a 2023 version of my phone. Have there been one since then?
yes, there is the 2024 one now. I would say they update it at least once a year, but it's not an annual update so much as they meet regularly. I forget how often all the medical directors are meeting, the different ChemSMAC or Connecticut EMS Medical Advisory Committee. Yeah, I got all the letters, ChemSMAC. So basically, when they get together enough and they sort of work through and they'll collect a few new protocols and then they'll roll a bunch out unless it's something that's like, oh man, we have got to get this out now.
It's moving a lot faster.
Yes, yeah. And here's the thing, ours are pretty good and relatively progressive compared to a lot of other states. In other words, we're as a state, we're not really being like held back like everybody else is doing stuff better than us. And they've really been working on stuff like refining that, like, hey, look, we want guidelines in these protocols that are more practical, more useful for people in the field. So they're really trying to do that. Cool. Any other questions you have? That's an excellent question.
They don't notify state licensed EMTs when they.
Well, Blair's been sending him out, but I don't have permission. I didn't ask for permission to send it.
Oh yeah. You can.
I got one email about it, but I haven't gotten any.
They have. I forget exactly. It's usually done via Everbridge. So I believe if you're in one of the state you're part of the state Everbridge system, if you're signed up for Everbridge somewhere, you can opt in as an EMT or a paramedic, a medical provider. I don't remember off the top of my head exactly how to do that because I haven't done it in a long time, and there was a little bit of a step-by-step.
Well, initially it was just like the representative was allowed, the higher level people were technically the lower ones weren't supposed to be able to, because they wanted a contact person.
Yeah, and for it to be rolled out through them. But yeah. And that's one of the reasons that we try to do this, is also this is an update, and that's why I thought this would help us build on the resuscitation stuff that we'd already been talking about. Anything else?
No, it's
Awesome.
thank you.
Absolutely. Like I say, little bit short and sweet, but if anything else comes up that you think of later on, everybody knows how to get a hold of me. So thank you very much.